Thank you so much, Stephanie. Hello, everyone. I am Catherine. I work for the Health Foundation. We're a think tank that looks control the health and charity in the UK. And I'm here today to present some work that we did with our colleagues from the University of Liverpool, where we project patterns of illness in the population of England over the next 2 decades, specifically between 2019 and 2040. Okay, so just a quick run through the format. So I'll go through the introduction of why, our research question, why it's important to do this, a section on the data that we use and the methodology, and then I will move on into the findings of our work as well as ending with the policy application. Right, okay, moving on to our research question. So what is it that we try and answer in this work? So here we focus on the current and the future burden of illness in England, and we try and answer whether the population of England will be spending more or less time with ill health over the next 2 decades. And also, if yes, what does that then mean for the numbers of people with illness? And what does that then subsequently mean for health? And how do we do this? We do this by combining administrative healthcare data, so linked primary, secondary care, mortality data, and I'll go into a little bit more detail in the data methodology section, with an epidemiological study of the drivers of long-term illness, which is done by the University of Liverpool. And why is this important? Well, anticipating and planning for how healthcare demand may change over time is really critical, so that you can make appropriate healthcare resourcing and funding decisions. And so you need to be able to understand how the future burden of illness is going to change, so that you then have a better handle of how healthcare demand is going to change, so you can make more appropriate healthcare resourcing decisions. And also quickly, just to show that, so obviously multi-mobility, we've already had a few presentations talking about multi-mobility, but I think where this project sort of stands out is because of a number of reasons. We use a microsimulation model, which enables more granular modeling and modeling at the individual level. We use, rather than just counts of conditions, we use something called the Cambridge Multi-Mobility Score, and I will come to that in the following sections, to measure multi-mobility, and it is weighted for individuals' healthcare use and their likelihood of dying. And also we use the best possible linked data set containing both primary care and hospital records, and we think that this provides rich insight into people's illness history. Okay, so moving on to the data that we use and our methodology. So we, like I mentioned, we have linked primary care and secondary care records. So for primary care, we use something called CPR-ORM. So a lot of you might be familiar with this clinical practice research data link, and specifically the ORM data set of it. It has multiple versions. And we have this, then patients' GP records then linked to their secondary care information through the hospital episode statistics, and we also have ONS mortality records as well linked to all these patients. We have a sample of around 1.7 million. We have socio-demographic information such as age, ethnicity, region in the data set, along with a history of all chronic conditions diagnosed in primary care. And we also have, we use risk factors. Like I said, we link risk factors with illness in this research. And so we have, these are the risk factors that we use, the behavioral ones being smoking, alcohol consumption, physical activity, fruit and veg, and then the biological risk factors on BMI, blood pressure, and total cholesterol. And this is not information that's contained in the study. This is coming from survey data, so that's survey data. Okay, so just quickly, so the impact NCD model, that is what the University of Liverpool's microsimulation model is called. This is something that they have been developing over a decade now. It's been extensively published. And what this does is it basically combines individual level data on demographics and major risk factors, and uses epidemiological evidence on the causal associations between these risk factors and the onset of illness and mortality. And so in microsimulation modeling, very simply, basically, we have a synthetic population mathematically living out their life. And each year they develop conditions based on the combination of what their social demographic characteristics are, their exposure to risk factors, and what conditions they have as well. And mortality as well, the probability of them dying will also depend on those things. So that's basically what this model is laying out here, where you can see that So the socio-demographic characteristics sort of affecting the risk factors in turn then affecting when somebody gets illness or incidence, as well as mortality, and those two together then determining the share of the population with the condition at a given point in time, so prevalence. And we then sort of aggregate that to look at how that then falls into multimorbidity or overall disease level. Right. So, like I mentioned, we are not just using counts of conditions, we're using something called Cambridge Multimorbidity Score here to measure illness. And so what this is doing is, this is a weighted score developed by researchers at the University of Cambridge, which consists of 20 of the most common illnesses, and together they make up around 2/3 of the burden of illness in England. I think the key thing that this does is it basically links conditions to, it incorporates the impact of these conditions on healthcare use, as well as their likelihood of dying. And so this makes it easier to then compare trends in illness over time, as well as the different population subgroups. And so you can just add up people's scores, and basically that is giving you then a measure of how much illness they have. For instance, you can see the conditions and descending on the weights, the 20 conditions. And in this research, I'm going to primarily focus on people with major illness. So this is a threshold we use where this is somebody with a Cambridge Multimorbidity Score of greater than 1.5. So this is the top 30% of people with illness. As well as if you look at the weights, you can see that 1.5 does a fairly good job of looking at multimorbidity, because except for dementia and cancer, you would have a score of 1.5, greater than 1.5, only if you had multiple long-term conditions. And so, again, I think the other key thing that comes out through this report is, so we look at the University of Liverpool have done this great research on the epidemiological research on the causal associations between the different risk factors, as well as illnesses. And what you can see here is, so this chart is basically showing the proportion of newly diagnosed cases or incident cases that can be attributed to the risk factors that we model. And so here you can see there are some key things are coming out. So you can see that, for instance, smoking and BMI, so the blue and the red, seem to explain a lot of the conditions that we have. You can see that there are certain conditions where around 2/3 of cases are explained by these risk factors. But I think what comes out really starkly is that there are quite a few conditions, actually a majority of the conditions, where we do not have quantitative evidence linking these risk factors with these illnesses. And so I think there is a real need, this sort of identifies a real need to then further explore this area. So there is a real gap in understanding how these risk factors determine these illnesses, but also I think this is where the wider determinants of health, so things where people's circumstances actually play a role, and probably that is then picking up. That is what is then causing a lot of these illnesses in addition to these risk factors. Okay, and then just some limitations of the research. So obviously, these are projections of current trends. These are baseline. We are assuming a certain trend in risk factors. So we can't really incorporate true levels of uncertainty. Like I showed in the previous graph, the evidence base for causal effects is quite limited. These projections are to 2040, which means that we can't really look at how the current things like the current childhood obesity crisis, how that will manifest, because those individuals are not going to reach the age where they will start getting chronic illness by 2040. The other thing is the CMS weights are static, so they're actually based on the impact on healthcare use and mortality in a particular year. And so that means that if, for instance, diabetes in the future were to result in lesser healthcare use, that is not something that is being picked up in this analysis. And also just to say that we are using healthcare records, so these results pertain to diagnosed illness, but there might be unmet need, which means this is not really reflecting the true public. Okay, so let's jump into the findings. So our key sort of finding is that the population in England is going to spend more time with what we call major illness, or a CMS score of greater than 1.5. In 2040 compared to 2019. So basically what this chart is showing is showing the average number of years a person lives in different states of ill health, right? So without illness, with some illness, and with major illness. And then the total length of the bar is life expectancy. So you can see that we project that people are going to be living longer over the next 2 decades. So a 1.5-year increase from 81.7 to 83.1 years. But at the same time, the age at which people are expected to be living with major illness, so that's the sort of 70, the sum of the gray and pink bars, are actually remaining fairly static. So this means that people are living longer, but the age at which they are expected to be living with major illness is fairly constant, which means that they will then spend more time with major illness. And that's what you see is the red bar at the end, where you can see that increasing from 11.2 to 12.6. So basically, if you think about it, you have a 1.5-year increase in life expectancy, but you also have a 1.5-year increase in time spent with major illness, which means all of the additional years of life are practically being spent. And so again, using the average Cambridge multimorbidity score, we can basically use that to measure the average level of illness for the population of England. And that's what this is showing here. And here we are excluding and including demographic changes. So for instance, if we assumed the population of 2040 to have the same size and structure as the population in 2019, then we see a more gradual increase in the average level of illness, so a 5% over 20 years. But that is not going to be the case. We know that the population is projected to be both larger and older with time. And so when you incorporate that projected population aging, then what you see is actually a 24% increase in the average level of illness in the population. And so what is exactly happening with the population? So why is the population projected to be larger and older? So we have some key trends basically driving the changes in the population structure. So we've been seeing low fertility from for over a few decades now, from 1980. And what this means is on the chart on the right, you can see that there is a big reduction in the number of people aged below 20 years over the next 2 decades. But at the same time, we also are going to see huge numbers of the baby boomers, so the large birth cohorts that you had in like 40s, 50s, and 60s, sort of entering and progressing through old age. And as well as we've seen life expectancy improvements over the past few decades as well. So those two together combined means that we will have a large increase in the number of people aged 60 and above as well. So you have a decrease in the population aged below 20 and a simultaneous increase in the population aged above 60. And so what does this then mean to numbers of people with illness? Because that's what then helps us understand the impact on healthcare demand a lot more. And so what we say is that there will be 2.5 million more people with major illness, again, over the next 2 decades, from 6.7 to over 9 million. So this is a 37% increase. And you can see that, again, the bulk of the increase is because of population aging. So the bulk of the increase is among the 70 plus group. So 80%, so the 2 million out of the 2.5 million is among the 70 plus group, but you still have a 500,000 increase among people aged 20 to 69 as well, so among the working ages. And again, this also has implications for how healthcare is financed, for instance, because the working age population contributes a lion's share of tax revenues, which is then used to finance these healthcare services. And so you can see that the working age population is only projected to grow by 4% compared with the 37% growth in the number of people. Okay, so we were looking at overall illness, but it's also important to look at how this impacts individual conditions to understand how this will then affect different healthcare settings. And so that's what we're going to look at in this section. So here what we're saying is the prevalence, so the share of the people with these 20 conditions and how they're going to increase the percentage change in prevalence between 2019 and 2040. So basically you can see that when we include population changes, so when we incorporate population aging, 19 out of our 20 conditions are going to increase between 2019 and 2040. The only exception is coronary heart disease, which is expected to fall, and this is because of long-run results, trends in stroke rates, as well as prescription patterns of statins and things like that. So, but largely 19 of 20 conditions are only. And again, it's important to not just look at the share of the people, but we would like to know what this means in terms of the numbers of people with different conditions. And so that's what this chart shows here. This is for a selection of conditions, not for the 20. but you can see that chronic pain and diabetes are going to see the largest increases in the number of people with illness, with those conditions, at over 1.5 million. And these are conditions that are largely managed in primary care, so obviously there are huge implications for those settings. We also project over a 30% increase in the number of people with conditions such as cancer, COPD, and chronic kidney disease. And again, this is to say this is not happening, this is largely happening because of population aging rather than people in a given age group getting more sick. I mean, this is so the bathtub is a very representation that's used by epidemiologists to understand why, how onset and mortality together determine prevalence. And so basically, if you think about why would the number of people living with morbidity increase over time, so if you think about the number of people with condition as a bathtub, the bath water coming in are the newly diagnosed cases, and then you have people either dying or going into remission, which is the tap at the bottom. So as long as incidence is greater than death or recovery, the level of bath water in the tap will always increase, right? And so a lot of times when things like prevention strategy, they generally, it's very difficult to just impact incidence and not death. So usually, so when you have things like prevention strategies, they would reduce both. So that's what is happening here is because we have incidence consistently higher than mortality is sort of why we are seeing this increase in prevalence. And also we are now increasingly good at treating symptoms and keeping people with illness alive, which again means that tap that flows out of the bottom is going down into a trickle. And that also then increases the level of water in the bathtub. And so that is if you had a constant population, but in addition, we also know that the population is projected to be larger than all that. So it's a combination of these two things that's basically showing the results that we see. Okay, so quickly, so trends in risk factors, because that's what we start with to then estimate illness. So risk factors are largely moving in the right direction actually over the next 2 decades. So if you look at the left chart, these are helpful risk factors or risk factors that we would want to increase for better population health, things like food and veg consumption, physical activity, and the ones on the right are the things that you want to reduce for better population health, so protein health or BMI, those sort of things. You can generally see that they are sort of going in the right direction. But one thing that you don't really see is quite unclear is BMI is actually increasing by a tiny bit here, which is the light blue line. And so that actually means that then obesity, which is the share of people with BMI above 30, is going to increase over the next 2 decades. So this is within age groups. You can see that except the oldest age group, BMI is actually going to increase for pretty much every age group. Obesity, the share of people with obesity is going to increase in pretty much every age group except the oldest age group. And this is a much slower increase than what we have seen in England in the past. So over the last sort of 3 decades, we've had an almost doubling of the share of the adult population living with obesity. But still, we do see an increase in obesity, and this would mean that a lot of people who are going to become older in the future would have been much more exposed to obesity, which then means greater risk exposure and then greater probability of developing disease. Okay, and just to then finally wrap up, so what does this then mean for healthcare services? So why should we care about these things, or what are the policy implications? So I think policymakers, we've understood that there is going to be a big increase in illness. So policymakers, it's important for them to understand the future landscape of illness to better prepare the healthcare system. But we also saw that it's not necessarily bad for society. It's a consequence of people living longer. It's a consequence of population aging. And so people are end up spending more time with chronic illness as a consequence of living longer. But one thing that we do know is that increasing prevalence of illness will mean increasing healthcare demand. And that is something that policymakers need to be prepared for. And some of the ways in which they can prepare for that is obviously primary prevention is very effective in delaying or at least avoiding more severe illness by targeting the risk factors that we saw associated with poor health. But also they can look at things like technological innovation and new models of care, which can enable earlier diagnosis and better management. population. Just to finish off, our findings obviously have implications for areas beyond healthcare as well. So the increase in major illness could mean that future recipients of social care might have more complex healthcare needs. It would have implications for welfare. For instance, the growth in the number of older people could increase those who qualify for age-related benefits. And as I mentioned earlier, even though the bulk of the increase in major illness is made up of people who are age 70 and above, we still see an increase of 500,000 people with major illness in working ages. And this obviously has huge implications for labor force participation rates. And it's clearly a very live issue, especially post the pandemic. You can see it in the press like all the time. So again, that has implications for the economy, for economic progress. And again, like we saw, people are living longer, but all of those additional years of life are going to be spent with major illness. And so this has huge implications for things like increasing state pension. So yeah, I think that's it. Yes, that's it.